forward to hearing to you.
Okay, ladies and gentlemen, first I would like to thank Professors Elona and Rolandas. I use the first name because I cannot pronounce the last names. Thanking them for having invited me. It's really nice to be here. First time I'm in Latvia and in Kaunas, and it's really very nice. Now, when Professor Ditko Niederwieser asked me to come here, I said, I can only talk about allogeneic transplants, and that's probably of little interest now. He said, well, you can talk about whether you can do something more to autologous transplants. So then we are in the autologous transplant field. So, okay, then I can talk about allogeneics. So that's what I'm going to do. I'm not going to talk about the drugs. You have heard so much about that, not focusing on these drugs. I will focus on whether you can do something further to the autologous transplant by adding an allogeneic transplant. And it's controversial, as you all know, and we'll see if we can come to any conclusion. I'm not sure about that, but at least you can see what the data is. So, if we now, this one? Uh-huh. Okay, that one, this one. This one. And then I put this one. Okay. Okay. So if we just analyze what the advantages, the strengths, and the weaknesses are of each methodology, autologous and allogeneic transplant respectively, you can say that the strength, in my opinion, of autologous transplant is that you give a very intensive treatment with the goal, of course, to obtain a stringent complete remission, still with relatively low transplant-related mortality. There is no graft versus host disease, as you have in allogeneic transplant, and together with novel drugs, you can make results very good today with an autologous transplant. So what are the weaknesses? Well, you don't have an immunological effect by the graft itself that you have in an allogeneic transplant. And in my opinion, there is no proof of having cured patients with autologous transplant. You can always find cases, occasional ones that might have been cured, but mainly it's not a curable methodology. So what about the allogeneic transplants? Well, of course, the infused cells, they are normal. There is no myeloma cells for sure among the infused cells. Maybe that is of little importance, but still it is, in my opinion, an advantage. There are immune active cells of different kinds, not only T cells, that could cause a graft versus myeloma effect that is well documented. But there are other cells as well that could be of importance, for example, NK cells, which I will come back to briefly. And maybe we have cured a few patients, a fraction of patients with multiple myeloma. I met recently my friend Michele Cavo from Italy, and he told me that the first patient they had transplanted in 1983 was still in complete remission and in good health and no signs of multiple myeloma. So that there are patients definitely that you could tell cure with usual definitions. So the weaknesses we all know about in allogeneic transplants, there's relatively high transplant-related mortality, 10 to 30%, dependent if you make upfront or later transplants. And then, of course, the graft versus host disease could cause morbidity and mortality. And also, maybe it's a disadvantage that you have to find a donor, but today, in fact, you find a donor to practically every patient. So what's the current situation? Well, autologous transplantation, as you have seen here, is, of course, in combination with novel drugs. That is a standard of care. And autologous transplantation is used upfront in eligible patients. That is patients usually under 70 years of age, something like that. And allogeneic transplant is rarely used, and some in the myeloma field mean that it shouldn't be used at all. And however, if you look at what's really done in Europe, you can see here in the registry, between 2003 and 2015, 7,000 allogeneic transplants were performed in Europe, despite this controversial issue. And if you look back from 1983, it's close to 10,000. Of course, it doesn't match at all what's done in autologous transplantation, where we have more than 100,000, as was mentioned by Laurent Garderet later, before that. Now, if we go back to the allogeneic transplants, in the early 2000s, the late 1900s, Rainer Storb in Seattle modified the technique and introduced the so-called reduced intensity conditioning, which had a lower transplant-related mortality. I'll come back to that. And if we look at what is done in Europe now, most patients receive reduced intensity conditioning, as you can see in this slide. And every year, there is about 400 or 500 patients done with this technique, and there are still quite a few patients done with standard myeloablative technique. Now, recently, Mohamed Sob made this investigation, including patients up to 2012, and this paper is now, in fact, accepted by Leukemia for publication. And what you can see in Europe, most transplants, 70%, are performed late in the course of the disease. It might not be a good idea, or I come back to that. While only 20% are done in this so-called tandem auto-allo transplant with practically always reduced intensity conditioning, and they are frequently done up front. Then allo transplant up front is done in about 12%, and they are frequently done, if it's not in tandem, with full conditioning. However, this was recently shown by Friose Sahibi that was less good than to do a tandem auto-transplant with with intensity conditioning. Now, could this combination with autologous transplant be a treatment that could improve results in multiple myeloma? Could the weaknesses be diminished and the strength utilized in order to get a higher fraction of patients in complete remission and long-term survival? Now we'll just briefly go through the NMAM 2000 study, which we published 3 times, in fact. So it has been in the literature. But just briefly, patients were included. This was now when the new drugs were, in fact, not there for upfront transplants. So it's the old VAD or VAD-like regimen with vincristine, idiomycin, and dexamethasone. So it's not an optimal induction, but that was how this study was designed. And then if you had a donor and sibling donor that was suitable, an identical sibling donor, then the patient was offered a allogeneic transplant after an autologous transplant, and if it had not, an autologous transplant was done, either single or tandem. So when we closed this study for entry and started to analyze, it looked like this. 357 patients were included. 108 was allocated to the auto-RIC allo and 249 to the auto. That's what you could expect if you use sibling donors. You can expect these proportions, which has been, I'll come back to that, another study being criticized for. That was the Italian study with how they had a totally different proportions of patients for auto and auto-RIC allo. Now, when we made this update, it's now a couple of years ago, and we are now working on it again. 49% of the auto-allo patients were alive and 37% of the autos. And they were relatively good match between them at entry, and I will not go into details in these figures. The auto-conditioning was the usual one, 200 milligram per square meter, and the allo-conditioning was the Seattle protocol, but we added fludarabine, which was not originally in the Seattle protocol. And acute and prevention of graft-versus-host disease was with mycophenolate mofetil and cyclosporin. And here are the relapse. The primary endpoint was progression-free survival. And this is what we could show. There was a significant better progression-free survival, 22% at 8 years as compared to 12% in the auto group or auto. And the overall survival was significantly better, but you can see there is a crossing over of curves around 3 years. And we also analyzed those patients that were really receiving the auto-allo. The previous ones were the intention to treat, and compared that to those who had a planned tandem auto. And the results are mainly the same. A better progression-free survival, a better overall survival, crossing curves a little later, between 3 and 4 years, to the advantage of the auto-allo. Now, how does that compare with other studies? Well, there are 6 studies, but mainly I would say the important studies is the Italian one, as you can see here, the HOVON one, the BMT-CTN, and the EBMT, because there are enough patients, and the PETIMA study is small, somewhat different design, and also the IFM, I would say, the first study had a different conditioning, and also they had a very high dose of ATG that we have found is a negative factor in allogeneic transplants. So if we now look at these 4 studies, you can see they are very similar, in fact. So the HOVON and the BMT-CTN studies, they claim they are not significantly better with the auto-allo procedure than the auto. If you compare them to the EBMT study, at 3 years, 43%, in fact, exactly the same in the BMT-CTN standard risk patients. At 8 years, 25% in the HOVON study, 22% in the EBMT study with the auto-allo procedure. So the differences are really not very great. Still, the HOVON study does not have significance for a difference in progression-free survival between the two. So you can now argue why. It could, of course, be because of different numbers of patients in the different groups and so forth. It's not significant. In the Italian group, it's significant, and in the BMT group, it's significant to the advantage of the auto-allo procedure. Now, the overall survival is about the same pattern. Very similar results in the auto-allo group between the big studies, HOVON, BMT-CTN, EBMT, and the Italian group, while the difference is not significant in 2 of the studies, the HOVON and BMT-CTN. So you can always discuss what the reason is for this. There is not a big difference in the procedures. We used TBI plus fludarabine. The HOVON had only TBI, and then they had a maintenance program that was not significantly different from the non-maintenance program, in fact. And also in the BMT-CTN, there was a maintenance program for some time, but it didn't show at that time any significant difference. So therefore, the different results cannot be explained by the conditioning method, in my opinion. Now, so we have to conclude that there are 2 studies out of 4 that are positive. There are 2 studies where there is no significant difference. So what about the impact of chromosomal aberrations? Well, in our study, we didn't do chromosome. It wasn't possible to do a good chromosomal aberration study. We only could analyze del 13, and here you can see the numbers where we had done it. And when you look at the results, they look more or less the same as for the whole group. That is a better progression-free survival and survival in the auto-RIC allo group. One interesting point is perhaps that, in fact, the del-13, that is supposed to be not a good prognostic parameter anymore, but maybe a surrogate marker to some extent for the more important ones, del-17 and so forth, was still a significantly, borderline significantly important prognostic factor here in the auto group, while it's not at all in the allo group, indicating that you can overcome the poor prognostic factors by a auto-allo procedure. Now, of course, this, since we don't have the more important chromosomal abnormalities, it's of course a weak evidence, I would say. Now, the reason for what you have seen before, the progression-free survival differences and the overall survival differences, were due to what you can expect, a difference in two parameters, and that is the lower relapse rate with the auto-RIC allo procedure and a higher mortality in the auto-RIC allo group, amounting to 15%. It is of course significant at 60 months. We had a 4% non-relapse mortality in the auto group. And of course, the graft-versus-host disease was an important cause for the mortality in the auto-RIC allo group, here amounting in acute GVHD to about 10%, 11%, while the chronic graft-versus-host disease was in fact important, amounting to 29% in this group of patients. So I will just show then one of the studies that was not significantly different that you saw before, the Hovon study. If you look, they recently tried to tell that there was no value in performing an auto-RIC allo transplantation. But when you looked at their data, the relapse rate was, as in our study, much higher with the tandem auto procedure than with the auto-RIC allo procedure. And they had about the same relapse rate. But as you saw, the outcome was not significant in their group for the progression-free survival and overall survival. Now we come back to the importance of the complete remission rate. And in fact, long before they started to talk about the importance of complete remission in autologous transplants, in 1995, we published this curve for allogeneic transplant showing a significantly better overall survival in patients that obtained complete remission than in those who did not. So this is not a very new finding, but of course an important finding. And if you then look in the NMAM 2000 study, the complete remission rate is significantly higher with the auto-RIC allo procedure than with the auto procedure. And this, as you can see here, corroborates, in fact, with one more study, that is a PETEMA study, although with few patients that also had a significantly better complete remission rate with the auto-RIC allo procedure. The BMT-CTN, you can see, is maybe borderline, but it's not significant, but the tendency is the same. Now, Simona Jacobelli used the NMAM 2000 study results to see how sustainable is a complete remission obtained with auto-RIC allo versus auto. And it turned out that the complete remission is significantly more sustainable if you have obtained it with an auto-RIC allo procedure, indicating that the quality of a complete remission with the auto-RIC allo procedure seems to be better than a complete remission obtained with the auto. So here you can see sustained complete remission at 10 years with 21% with the auto-RIC allo procedure compared to 8% with the auto procedure. Now, Nicholas Kröger and many others have looked at MRD. I'll just show this slide from the Hamburg experience of 76 patients who had received an auto-allo tandem procedure, and you can see this enormously good overall survival in MRD negative patients, 15 patients, that is close to 90% up to 8-9 years from transplant, while if you do not obtain a negative MRD, the results are much poorer. And this has been done also in the Italian group, where you can see to the left the overall survival in a cohort of patients that were then regrouped in those who obtained a minimal residual disease negative, were negative for minimal residual disease and positive, and they have close to 80% overall survival up to 12 years if you had a molecular remission. So it is indeed important, but as I alluded to it before, it would have been better if we knew it from the beginning and could then design our therapy based on those who will not obtain a molecular remission. Now we'll just mention a few words about treatment of relapse, and I must admit there are no very good data on the treatment of relapse with allogeneic transplant in multiple myeloma. What we saw in the NMAN 2000 study, and are working on it now, is that after relapse, the autologous allo group that had this up front had a better survival from the time of relapse than the auto patients. And that could, of course, be many reasons for that. It could be the procedure itself from the beginning, but it could also be how you treat the patient at relapse and how the patient respond at relapse. And maybe the autologous allo patient respond differently and better to some drugs after relapse. So we are investigating that now. It could also be due to the fact that you can give DLI after relapse, and that was done in 16 patients, 25%. And, but most of the patients, we don't know yet how they were treated, and that is now a study ongoing. You can see that DLI is not a bad method to treat relapse. 7 patients responded out of the 16. And here you can see also that the survival and these complete remitters is significant, up to 8 to 9 years. And even in partial remission, they have survived for quite a long time after DLI. Now, there is a retrospective study on the treatment of relapse with allogeneic transplants by Patriarca et al., and that is in Dr. Ensinger's group. And they picked out patients that had a donor at the beginning and those who had not. And those who had a donor, they were offered an allogeneic transplant, and 68 patients of those were treated with actually an allo group with a tandem allo transplant. And all patients, both groups, were treated with novel drugs. So here you have novel drugs included, and they were relatively well matched from the beginning. But when you look at the progression-free survival, it was significantly better in the group that received the allogeneic transplant. And what I think is more important or interesting is that progression-free survival and survival was the same, similar, in patients that had del-17p or not in the group that had an allogeneic transplant, while in those who were not treated with an allogeneic transplant, the prognosis with del-17 was as bad as you have seen in many other studies. So maybe this was a way to overcome the poor impact of the 17p abnormality. Now, I'll just show one slide from the study made by Mohammed Sob in the EBMT registry, and he told me that it's important that I do not show this slide as a comparison really between the different groups, But nevertheless, I think it is an important slide. It shows that it could be of value to perform a late allogeneic transplant. As you see, the 5-year survival is 24%, the red curve, even if you have had more than 2 autologous transplants earlier. So it's not out of the question. Still, I think usually a late allogeneic transplant is not a very good, you can also turn it around that at this time about 80% of the patients were dead. So, of course, the other option, tandem auto allo, the green one, is significantly better, 53% at 5 years. And also, you end up with a group of patients that is significantly higher with the upfront procedure, while, in fact, about close to 20% are long-term survival, even if you perform it in relapse. So it could be considered, and we did in Minneapolis recently an agreement that was published recently when and how you could consider an allogeneic transplant, particularly in those patients who relapse early after an autologous transplant. Now, this is a study that I just want to show because a single center study could be of interest, a center that had a good knowledge about allogeneic transplant. And here you can see that the tandem autorig procedure in the Utrecht hospital, 147 patients, where you compare 57 with first-line tandem auto allo as compared to relapse. And here you can see at 10 years, 50% of the patients survived. And you can see that there are many patients out at the curve more than 10 years from the start of treatment. And I think this center has extremely good results. And I'm sorry to say that we cannot show the same good result at Huddinge Hospital. These are very, very good. And it was published just this year. So what are we going to do to add to autologous transplant in the future? What are the future's perspective? What can we do to change allogeneic transplants? Well, we have a small series of patients where we have tried another conditioning that was actually started, I think, in Würzburg by fludarabine and treosulfan, which is a prodrug, chemically very similar to busulfan, but a totally different action. And we have transplanted 2 patients up front, 7 second line, and in fact 2 third line, and there's only 1 death out of these patients so far. We are following them up to 3 years, while the earlier protocol, of course, followed for a longer period of time, seems to be less good. There is also now a joint venture with the European Myeloma Net, EBMT, where a phase 2 trial where the new drugs are incorporated in patients with high-risk features, early relapse, as I mentioned before, here before 24 months from start of treatment, and in first relapse that does not enter complete remission, and in patients with poor cytogenetics are included in the study, which incorporate bortezomib before fludarabine, and then before the allotransplant, and also after. And the melphalan dose is reduced, 70 milligram per square meter, and then there is a program for graft-versus-host prevention with methotrexate and tacrolimus. And so far, I've heard from José Pérez-Simón that the study is going well, and we do not know the final result, of course, yet. And this continues with intensification with bortezomib, and then after 180 days, lenalidomide maintenance. Maintenance with lenalidomide should not start very early if after an allogeneic transplant, because that usually gives very severe graft-versus-host disease. But if you wait until 180 days, these problems seem to be eliminated. Now, is there anything else we can do? Well, we have worked with NK cells. That is a very interesting cell that you do not need immunization beforehand in order to have this immunological effect which you can get with an NK cells. It has inhibitory receptors and activating receptors that you have to play with, try to activate the activating ones, and we have had a project on this. Expanded cells from an animal model have been shown to, together with IL-2, to give a much better overall survival in mice than in control groups. And more interesting perhaps is that we have been able to expand the NK cells from patients with multiple myeloma without expanding other types of cells. And at 21 days, you have NK cells that have highly lytic characteristics to kill myeloma cells. And now we have a clinical protocol where we try to incorporate NK cells after an autologous transplant in the autologous setting. So this is just a brief outline of the program. You harvest the cells at the diagnosis when you harvest cells for the autologous transplant, and then they are expanded in a bioreactor, and you can expand them about 1,000 folds, and then they are characterized, and here you can see how the flow is. Well, I'll do it this way. Here, the cells are expanded, they're cryopreserved. You start infusions after the autologous transplantation. And in order to see, this is a phase 1 study for safety, but we also try to find, so it's a phase 1, phase 2, to find efficacy parameters. So therefore, we want to have stable partial remission or subclinical relapses in order to follow the immunoglobulins to see whether there is any reaction at all. And here you can see the first 3 patients that we have done. Here is a stable partial remission. And when we give the cells down here, there is a sharp drop in immunoglobulins in both these patients. It's not so clear in this patient. So there is an efficacy of the NK cells on the immunoglobulins, and that we interpret as an efficacy on the myeloma. And I think that this could be an additional type of treatment to the autologous transplant in order perhaps to induce a better outcome for the patients. Now, so I will conclude with this, that the addition of reduced intensity conditioning allotransplantation to an auto transplant is controversial, as you all know, and there are conflicting results. But out of 4 good studies, I would say, 2 of them show that the the combination of autologous and allo-reduced intensity conditioning is long-term superior. But there is an initial high transplant-related mortality, not very high, but 10 to 15%. And of course, that has to be considered if you want to offer a patient an early transplant. The Minneapolis conclusion was not to include even high-risk patients upfront, but in relapse. And I think so far, maybe it's wise to follow that advice unless you do a new upfront trial where this method with new drugs could be treated. But that should probably wait until we have seen the results of the EBMT joint study. And with this, I thank you very much for your attention, and I'm willing to respond to questions.
Thank you very much, Professor Garton. Before I start the discussion, I would like to ask you one simple question. after having, we were talking quite a lot about MRD positivity after various settings in the treatment of myeloma. In case that you have a patient who is MRD positive, would you induce a maintenance therapy, or would you, and if yes, which one?
If you have a MRD positive after an autologous transplant, that is not a relapse, but it's persistent. According to what we said in Minneapolis, it would not automatically be an allogeneic transplant at that time. What we united on was that it should be a relapse. So that's my answer. I have to stick to this type of answer.
Okay.
I personally, if I say, I wouldn't be totally against, under circumstance, depending on what kind of patient it is, I mean, to perform a tandem auto at that time.
Okay, thank you. Are there any questions from the auditorium?
Well, the REEC option is selected because of age-related comorbidity, of course. So, well, we have it. We know since long that REEC is not good for patients with residual disease. Many studies done in acute leukemia, like Martino's big overview and so, proved it. So, very important in this auto-allo setting is the gap between one and second procedure. I know from practice that nowadays, if you are doing a lot of transplant, you are obliged to follow the rules you have, so patients are waiting. If you look at registry data, of course, you never know what happened behind. I'm speaking about this slide by Mahmet. But in your study, you plan the time of performing REEC after auto, not to have too long time when the tumor load will grow higher. How was it in this trial?
Yeah, in fact, we amended the protocol to say that it should be done within 5 to 6 months, the second transplant.
But it might be in dynamic disease too long.
Right. This is this was mainly followed, I would say, that it was done within that time.
My second comment concerns this treosulfan trial. I took part with Swedish treosulfan, yes. So we did dose escalating study for acute leukemia MDS in the very past, and that time we found 14 grams per dose. Then I know now the interim results of head-to-head study in acute myeloid leukemia, and it was found that this 14 appears to be too toxic for younger population. So what's your dose here?
No, we used 14.
14.
Yeah,
so it's good.
Yeah.
So it's recognized as non-myeloablative because of fludarabine, but in the matter of fact, if you use 5 times 14, you are getting patient to complete aplasia. So maybe this will be a good solution.
I think it's still considered to be not as much REEC as a 200 centigrade total body rate, somewhat higher. It's somewhat more intensive, but this is what we have used.
This trial, World Cup, I would say, was stopped because the design was so that there were patients age 50 to 65 for this trial, and this 14 gram was probably too strong. We dealt with whole population 18 to 65, to 60 before.
Yeah.
So
well, as far as I've seen, this is Per Ljungmann's study actually, and he claims that it's relatively little side effects.
Promising, I think. Thank you.
Any other questions? Okay, thank you, Professor Garton.
Thank you.
And I'm also I'm very happy to have the opportunity to announce